Diane Cousins is speaker 5 of 5 on this conference call. She is a health scientist administrator with the Agency for Healthcare Research and Quality's Center for Quality and Patient Safety. That means she's got a very long business card. Diane, where are you calling from?
Hi, Nick. I'm actually in Rockville, Maryland, not far.
Ah, okay. I was wondering whether you were on a balcony in Waikiki Beach, in Washington, Jefferson City. So now we know you're in Maryland.
Yeah.
And so tell us, how do you connect then? What is the Agency for Healthcare Research and Quality, and how are you involved in improving patient safety and minimizing medical mistakes?
Thanks, Nick. The Agency for Healthcare Research and Quality is one of several agencies under the U.S. Department of Health and Human Services. And although its history has been primarily in research, we have begun to focus more on how we can take the products of our research and turn them into practical tools to improve quality and safety in healthcare. And of course, with the increased attention on President Obama's healthcare efforts, the agency has played a key role in helping to design what will become the game plan for healthcare for the future. So I'm here to talk to you today about patient safety organizations, and I thought I would just start with a word of background. In its 1999 report to Error is Human, the Institute of Medicine recognized that for errors to diminish significantly in healthcare, voluntary reporting programs need to be able to operate in a way that enable healthcare providers to fully and honestly disclose information about errors in a way that supports a culture of safety and creates a learning system for healthcare. It wasn't until 8 years later that President Bush actually signed into law the Patient Safety and Quality Improvement Act of 2005, with implementing regulations published in January of 2009. So we've been doing this now for about 2 years, creating patient safety organizations. And what this statute does, it provides 4 important things consistent with the IOM recommendations. First, it provides confidentiality and privilege protections for reporting to PSOs, so removing a major barrier to learning. It allows the government to create standardized formats that'll help enable the information to be shared across health systems so that trends and patterns can be identified. It charges the Secretary of Health and Human Services with facilitating the development of a national repository of non-identifiable information that's publicly available. And lastly, it requires us to report the findings in the National Quality and Disparities Reports. Now, if you know about peer review protections provided under many state laws, they often cover physicians in hospitals, but not other healthcare providers or other settings. And the Patient Safety Act will protect all healthcare providers more broadly in all settings as long as reporting is done to an AHRQ-listed PSO. There are 78 PSOs in 28 states and the district, and regardless of what state the PSO is established, a PSO can operate nationwide, statewide, or regionally within or across state borders. Unlike mandatory reporting programs that are created more for accountability, these voluntary reporting programs are structured to support learning. PSOs are established voluntarily. There is no federal funding provided. Reporting by providers is voluntary. In fact, PSOs collect information on a variety of topics that they choose. And when the national database is operational late this year, early next year, participation by providers in PSOs will be voluntary. Now, a PSO can be any public or private organization, any for-profit or not-for-profit entity, or a unit or division within these entities. And a PSO is listed by AHRQ for 3-year renewable periods, and some PSOs are brand new businesses, some are long-standing organizations that have been focused on quality and safety. Some collect quality events, others collect safety events, and some collect both. Several PSOs are a component of state hospital associations. Some focus in highly specialized area like the area of the American Association of Blood Banks. And lately we've had a few specialty societies form PSOs, like the Society for Hospital Medicine, the Society for Vascular Surgery, and the American Society of Anesthesiologists. Now, Some providers choose to work with more than one PSO to meet their needs. So whether PSOs focus on one topic area or across the broad range of issues, there are healthcare providers that are eager to work with them. While PSOs differ dramatically in their structure, their operations, the areas they focus on, the providers they serve, and their business models, what they do fundamentally is dictated by statute and the 8 patient safety activities that it stipulates. And I would summarize them this way. PSOs collect data, they apply their expertise to analyze it, and they feed back information that contributes to the improvement of processes and systems. They encourage what we call a culture of safety, and they ultimately minimize risks to patients. So how do patients actually benefit from this statute? Well, the broader sharing of information among providers helps to understand and address problems that affect the quality of care and the safety of patients. When patients are harmed, they can still access information that's available in the general records and that are part of the operations of the facility, like the medical records. This act also provides that patients can be informed of the incidents that happen to them or to their family members. So as providers address these problems more openly through a culture of safety, the risks to patients will be lessened. How do providers benefit from working with a PSO? And you've heard a lot of great examples in the speakers today, particularly from Becky about the Missouri PSO. But in addition to this act providing uniform federal protections for confidentiality and legal privilege, these protections also apply at various levels. They apply to the reporting facility, to the practitioners who submit the reports, and to any practitioners involved in the event. Also, the provider can benefit from new levels of information sharing within the protected space. They can share this information among multiple providers who work with a PSO, as in the case of the Missouri Center for Patient Safety. They can share, these PSOs can share among the other PSOs, and they can share, a PSO can share its information with a national network for comparisons to national frequencies and trends. Now, ARC has published common definitions and reporting formats that hospitals and skilled nursing facilities and others will be able to use over time. Their scope includes not only incidents or severe harm incidents, but also near misses and unsafe conditions. So we can look at the broad range of threats to patient safety and quality. For the future, hospitals will be affected by 2 provisions of the Affordable Care Act that will interact with the world of PSOs. And first, in about a year, hospitals that have high readmission rates, high being above some threshold that is yet to be decided, can work with patient safety organizations to implement programs to improve those readmission rates. And second, by 2015, hospitals over 50 beds will need to utilize what they call patient safety evaluation system in the law. And this basically means that these hospitals will need to report to a PSO in order to participate in the insurance exchanges that are set up by the Affordable Care Act. So many of us are watching these sections very carefully to see how they will develop and the new opportunities that they're going to provide for PSOs to provide the expertise and services that are valued by healthcare. We'll learn more as the year progresses and as these relationships take place and the budgeting for these areas takes shape. That concludes my presentation. I'd be happy to answer any questions. Nick?
Diane Cousins, thank you very much, with the Agency for Healthcare Research and Quality in Rockville, Maryland. We've got some of the guests still on the line with us. Any other questions of our panelists?
Yes. For Diane, I guess I was curious, is there any pushback from those patient safety organizations about the cost of treating a hospital-acquired infection? It's my understanding that often falls to the patient to pay for a condition that they acquired from a surgery or, a hospital. Is there any sort of movement toward, making some sort of financial assistance available to those patients?
ARC isn't really involved in financing those activities per se. We do, however, have a very large portfolio of research focusing on healthcare-associated infections. We also have PSOs that are collecting information on healthcare-associated infections. Some of our common reporting formats provide them the basis to create this information in a standardized way. And when the national database takes shape at the end of this year, we'll start to see that information flow from the providers through the PSOs and eventually to the national database. So we'll see what the extent and the nature of these issues are beyond those things that we already know. This gives AHRQ a very unique opportunity to design further research or implement the results of existing research in ways that can benefit healthcare in the long run.